it is difficult to determine the correct diagnosis for a patient based on their symptoms many a times. So sometimes they give symptoms which are atypical presentation of a disease, overlapping symptoms between multiple conditions, incomplete or any conflicting test results, rare or uncommon disorders, coexisting conditions that obscure the clinical picture. So, this is what it poses as a diagnostic dilemma in day to day practice. And how do we approach it? So, we do a step by step thorough clinical examination. Experienced practitioners, we all are there who are doing clinical examination, but just to revisit and to see how it can be done better. So we do a screening of the oral cavity more or less day in day out. We see teeth, we are diagnosing the condition of the teeth, we see caries, we see patients which require root canal, which require cleanup. But how do we screen the entire oral cavity? So coincidentally there are 80%, 70% of the oral cavity is left without any screening whenever a patient comes for a routine checkup, because we only end up reflecting the buccal mucosa and just seeing the teeth. So in that situation, what we miss out is all the soft tissue. And most of these diagnostic dilemmas that encounter, that the cases which come, they complain of some burning sensation, they complain of some ulcers, they complain of a growth. It's apart from the routine. So we have to revisit the screening of the oral cavity. So in this screening, what we see is how we reflect the buccal mucosa, labial mucosa, and we observe by drying. We use a sterile gauze, and we are going to check each and every aspect of not only the hard tissue, but as well as the soft tissue in the oral cavity. A good amount of illumination is needed, and obviously the barrier protection with the sterile examination gloves and the sterile gauze. So here what we are examining is the labial mucosa. We have to have a good amount of reflection to see it thoroughly. Here when we examine the buccal mucosa, and even you can use like something like a mouth mirror to retract it. But here it's preferable that we always inspect and also palpate with a gloved fingers. Here we are seeing the lower labial mucosa, the vestibular area, how the amount of reflection that is needed to actually thoroughly examine and screen the oral cavity. Why is this important? Because most of the cases that we will be discussing today, it was that you have to begin with a proper screening, a step-by-step thorough clinical examination. Here we can observe the hard palate, how we are seeing it directly with the, not with the indirect vision, but try to have a direct vision with a good illumination. And then we can observe the structures of the hard palate. We are all aware that the normal color of the oral mucosa is pale pink and coral pink in certain textbooks, but in Indian population, more of like a pale pink. So we need to know the color and consistency as well. Here, the tonsillar area, which we frequently miss out examining the posterior most part of the mouth of the oral cavity. So what we have to do is basically ask the patient to protrude the tongue out and say the word ha. And then we can easily see the tonsillar area as well and the soft palate area. Similarly, the ventral surface of the tongue, which is the surface which is underneath the tongue. So we miss out on these areas as well, the floor of the mouth. Very, very important to examine these areas. How we can see here, we can examine the lateral border of the tongue, where we are seeing that, a gauze is being used here, a sterile gauze. We can have a nice grip at the tip, gently protrude, help the patient protrude the tongue and just move it to both the sides to see the lateral borders of the tongue. So this is a summary of the same. And what we are observing is the entire step-by-step thorough clinical examination, which is a prerequisite to basically understand or to diagnose the dilemma which we will be encountering in our day-to-day practice. So what we are observing here, certain challenges. Sometimes what we do is just see the hard tissue, just the teeth, and we are like, okay, this is the caries, this is some periodontal condition, gingivitis, or we'll just do a scaling. But then apart from the routine, we have to do a thorough clinical examination of the entire oral cavity. So what is the reflection on real life case presentation. What we see here is an investigative approach. So what is an investigative approach? It is exactly what it means is how we investigate. We if we have a doubt, so we ask what, where, why, when, and we have to ask the patients a detailed history. And with that, the patient, for example, if they say that I don't know how I got this white patch, and if the patient is having a white patch on the lateral border of the tongue and also on the buccal mucosa, so we are suspecting something like a pre-malignant or a potentially malignant disorder. In that situation, the patient will say, "No, I don't never smoked. I have never had any kind of any form of tobacco, or never even tried any e-cigarettes or anything like that. I don't even drink." So we have to consider that. And first of all, we have to also check that sometimes do patients end up lying a bit. But then if they're saying the truth, then the investigative approach is we have to investigate and check. It could be a candidal lesion, it could be a fungal infection which looks very similar to a white patch. So in that situation, what we do is we scrape and we check the part of the mucosa again with that reflection that we saw. And we scrape that part with the sterile gauze. And if it scrapes off, we can say with certain confirmation that it could be a superimposed or a fungal infection. We can give antifungal agents. If not, we can even do some chair side test and then check if there is a candidal infection and it was not leukoplakia, because the treatment for both will differ. And if it's leukoplakia, we'll do a biopsy, but in obviously we'll have to cut the patient and check the biopsy. But in this situation, antifungals for candidal infection will suffice, and we don't need to actually put that patient through a biopsy. So if to understand how we have to have an approach like an investigative officer, and like the doctor is actually thinking of all these questions when such kind of diagnostic dilemmas occur. And it will better understand it here in this situation when we will talk about the evidence based case discussion. So, what is this case discussion? So, we have certain cases that I have seen myself, and I'll be sharing it with you all, my experiences about the diagnostic dilemmas in dentistry. So, what is the first case we will be discussing? This is the first case where again we have seen some patients who come to us who come and complain that they have reduced mouth opening. And reduced mouth opening, they also sometimes complain of a burning sensation whenever they consume spicy food. They When we examine, when we see signs, and when the patient gives their symptoms, there is blanching of the oral mucosa, there is decrease in the mouth opening that we are seeing, and fibrous bands are palpable when we reflect the buccal mucosa and check with our gloved finger when we do the examination. So here we can see that it is approximately 25 mm interincisal distance in this particular case. So it poses as a diagnostic dilemma. Here, after asking more history from the patient, this patient was a male, uh, approximately 45 to 50 years of age, saying that we have a particular burning sensation. Immediately we jump and think it could be OSMN. We are just jumping in and seeing that, okay, these are the features intraorally. We can see the posterior most part of the palate. This is a typical feature of the oral submucous fibrosis, where we can observe a J-shaped or a hockey stick shaped uvula. We can see a lot amount of blanching in the posterior most part of the palate. And here we can see a small amount of ulceration also present on the uvula. When we are seeing the intraoral picture of the same patient, we are observing that there are a lot of these stains. So looking at that, obviously we ask the patient, do you consume any form of pan masala or any kind of tobacco? They say yes to everything. And we are also seeing that because of that constant grinding, there is attrition, and it has caused these sharp edges on the teeth, which are irritating the buccal mucosa. And we can see that it has a blanched appearance with certain amount of erythema here. When we palpated these areas, it also showed us fibrous bands which were palpable. In this particular area, we can observe the erythema. If we closely see here, as the pointer is showing, that this has a slight amount of ulceration as well. That was because of the constant grinding, and there was cheek biting also involved. So those sharp cusp or the sharp teeth are causing that added trauma, because it becomes an entirely like a vicious cycle. Decreased mouth opening, thick fibrous band in the buccal mucosa will start getting the buccal mucosa closer, and there are sharp teeth next to it. And when the patient is going to chew or bite, they are going to cause damage to their own buccal mucosa, and the entire cycle repeats itself. So it is not directly that we jump and say it's a oral submucous fibrosis. There are certain differential diagnoses as well, like scleroderma, anemia, or a lichen sclerosis. When we confirm with the patient that these are the habits that they are having, where they are having more of spicy food, where they are having more of areca nut based pan masala. There are so many variants out there and so many ways of consuming that we actually have to thoroughly ask the patient about the tobacco and the pan masala history. Based on that, we could say yes, it is oral submucous fibrosis, and this is the basic classification of the grading, grade 1 to 4 for oral submucous fibrosis, depending on so many factors. It is multifactorial: clinical, functional, histopathological treatment, and what will be the prognosis based on that particular grade. Now, if the mouth opening is in this particular case, the gradation is grade 3, 15 to 25 mm of the mouth opening was present at the first visit. And if it becomes more severe, it will be less than 15 mm or even negligible, even nil in certain cases. And there is higher chance of a malignant transformation in that particular case. If it is grade 1, then there is an excellent prognosis, mouth opening is good. So this is where the patient should be after the treatment. And what are the lines of treatment? So here, this is one for further reading. You can refer this particular article on OSMF. And there are certain new classifications which were introduced for this particular condition. Now, when we see here, based on the clinical picture from the first and the sixth visit, this patient was kept on a strict follow-up, and they were asked to visit every week. After every week, we had evaluated, and say after 6 weeks, we saw certain condition which was improving. First and foremost, the most important thing is to break the habit, cessation of the habit, which requires a lot of patient education and motivation. So in that particular case, what we are seeing here is that the erythema is all gone, the amount of blanching has reduced, and moreover, when we are seeing that the mouth opening was also improved by almost 10 millimeters in a span of 1.5 months. So what helped here was a treatment plan which ensured that the first is cessation of the habit, and then when we evaluated this particular patient, they said that because we are having so much of tobacco, so our the pan masala and mixed with tobacco, with slake lime, etc., whatever they end up using, that they used to not feel hungry. And we see that yes, many a times that it suppresses the hunger. That is why it affects a lower socioeconomic group. In that situation, they have only one meal a day, which was also a nutritional deficiency. So in that situation, in this particular case, we told the patient and educated the patient to eat less of the pan masala and more of the home cooked meals. That also played a very, very important role, because the nutritional deficiency which was getting created, it ultimately reduced. Oral physiotherapy was employed. Oral physiotherapy is something that we have to teach them, basically jaw stretching, mouth opening exercises. There's a exercise where we ask the patient to inflate a balloon, so that when they're inflating the balloon, there is a pressure which is generated in the oral cavity, and it causes expansion and breakage of the fibrosis which is being formed in the buccal mucosa, and a strict follow-up. Only when the patient is educated and motivated enough is when they will see, okay, they understand the seriousness, that what could be the consequences if this thing remains unchecked. This particular condition, oral submucous fibrosis, can have a 7 to 23% chance of malignant transformation based on some recent literature, and it is ever increasing because it has so many multifactorial things to be considered. And then one more thing that we did here for the treatment was we asked the patient to use turmeric application. So this turmeric was sourced naturally. There was an Ayurvedic part which was also added in the treatment plan, which also helped the patient. So a paste of the turmeric was freshly prepared. Patient was given a particular powder of the turmeric, and then it was mixed with glycerine so that it became a paste, and the topical application was advised in this particular case. The oral submucous fibrosis has a new classification as well. It's called a TFM classification and staging. So what does this TFM mean? It is just like how we say TNM classification. So here it is TFM. T means trismus, F means fibrosis, and M are the chances for or the signs of a malignant transformation. So this is just for understanding a new classification and staging, that is trismus, Tx, T0, T1. It's very similar to the TNM. Here we are talking about the trismus, that is the interincisal distance. Based on that, it is T0, 1, 2, 3. Fibrosis, F0, no signs of fibrosis. Fibrosis cannot be assessed because there is severe trismus, that is FX, F1 to 4, depending on the amount of fibrosis which is examined on palpation. Malignant transformation, if there is any, based on the histopathology. Now, certain cases, yes, we do advise a biopsy, especially if there is a suspicious lesion where there is a ulceration or an unhealing ulcer along with the oral submucous fibrosis. Otherwise, first we keep the patient on a follow-up, not immediately jumping into a biopsy. But what do we see? What do we look if we are taking a biopsy on any suspicious part, especially where there is a erythema, where there is a red patch, or there is anything which is a alarming red color. So in that situation, we see some kind of an atrophic epithelium. We see a lot of features where there is thick, dense fibrosis in the connective tissue area here. What do we see in the epithelium? This is true for any of the potentially malignant disorders that we are seeing, potentially malignant diseases, which is the newer term, or in olden times we used to call it pre-malignant or a pre-malignant condition or a pre-malignant lesion, even leukoplakia. What we are seeing on the biopsy is basically dysplastic features. Now, dysplasia means bad. Dys means bad. Basically, it's a bad cell. So we see cellular atypia, pleomorphism, variation in the size and the shape of the cells, hyperchromatic nuclei, altered nuclear to cytoplasmic ratio. Normally it is 1 is to 4. In these particular conditions, it is 1 is to 1. So the nucleus is as big as the cell. Mitotic figures are more abundant, and there is loss of cellular polarity. Now, all this can have a higher significance when there is a chance of a malignant transformation of any potentially malignant disorder. So these things have to be considered. And for OSMF, when we see it day to day, sometimes we are having an early stage, intermediate stage, or an advanced stage based on these histopathological features. So apart from that, what we are seeing here in this is the treatment planning that we do and the approach that we have. It depends on the case. It is unique to a case, and you have to connect with the patient. Otherwise, then they are going to take it for granted and continue the same habit. 21 days is very, very important. So any habit breaking, it requires 21 days. So ensure that you see the patient at least consecutively for 3 weeks and keep a follow-up with them, whether they've stopped their smoking, whether they have reduced smoking, pan masala, whatever kind of habits that they have which are deleterious to their oral and overall health. In the next case, what we have here is the second case here, where see the way we have reflected the mucosa here. This is the lower label mucosa. And what we see here is a young individual, a female, 20, 22-year-old female, where, the complaint was that this is a kind of a growth, which is there, which is painless, which was smaller in size few years ago. So the patient had ignored it, saying probably, it will just go on its own. And gradually it had increased in its size. So in the next 1 2 years, it grew up to this size, and then it became concerning to the patient. Again, being a female, it was even an aesthetic concern. So not only an aesthetic, but even they got scared that could it be a cancer. So here in this situation that the patient had approached here, and what we saw was this particular growth on the right side of the lower label mucosa. We could even observe this some areas with the aphthous ulceration on top of this particular lesion. So when we are seeing this, Obviously, the first treatment plan here is to basically have a surgical excision and go for a gold standard histopathology evaluation. In that, what we are observing here is the entire growth was removed here. It was basically we see the size, site, the shape, the color, and the consistency. So all that what we're seeing, it's more or less oval. And once it was removed, there was on follow up there was no issues. There was uninterrupted healing and uneventful healing in that area. But what we did with this particular the mass which had come out here, we could observe this on the macroscopic feature, that is the gross features. So we had actually processed it and seen the histopathology. Now, provisionally, before any before the surgical excision, it was planned or it was provisionally diagnosed as a fibroma, as a fibroma. But however, in the histopathology, we could appreciate that it is in certain areas it is a fibroma, but there was a area where there were these lipomatters or the adipose tissue. So there was adipose tissue along with the fibrous tissue. So in that particular case, what we could call it was a fibrolipoma. Now, fibrolipoma is a very rare tumor to occur. It's a very rare tumor to occur, especially even on the lower lip. So I think this was a ninth case report of fibrolipoma here, and this was on the follow-up. The patient had a follow-up here, and there was uneventful healing. So this was a very rare case to occur in the oral cavity. So this is an article that it was published for further reading. In a young individual, it was a very rare presentation. So routinely what we feel, yeah, it could be just a fibroma. Certain situations where I have also experienced that many a times there are not to say, but not to say it in a very bad way, but certain time that some people excise a mucocele they feel and they just discard it. It is not subjected to a histopathological evaluation. It should be checked upon because every growth or every swelling which is occurring on the lower lip, what we feel usually every time is it could be a mucocele. So it is not that every growth or swelling occurring there is a mucosal. It has to be sent for histopathological evaluation, and only then it can be given as a final diagnosis. Because here also we felt that it could be a fibroma, could be a mucosal which is still growing. There is still amount of mucus retention which is happening, so it is still growing. But what we saw was a fibrolipoma of a lip in a young individual, a rare presentation. Now we come to the third case. Yeah. So in this third case, what we are seeing is basically we did a, so just to give you all an idea, this is a female patient, approximately 42 years of age. And the complaint of this patient was that they had a burning sensation in their mouth. Again, no history of tobacco. Like how we saw case one, there was a history of tobacco, pan masala, all possible things. But in this particular case, you can even notice the hard tissue here. You can see the teeth. They have no tobacco stains, no ugly looking yellow brown stains. So that is a sign that the patient is telling the truth, that there is no smoking or any kind of tobacco history. So what we could see here inside is, yeah, there is a burning sensation which is persistent. They had visited many doctors before and they were given mostly steroids and topical agents to apply. Just even sometimes they had visited just the chemist, and here we have that they just get it over the counter. They started applying it, but they had no relief. In fact, in certain times the situation became worse. Now here, when we did an intraoral examination, again good amount of illumination and reflection, we could see certain gray white patches, gray white areas on both the buccal mucosa, that is on the right as well as the left buccal mucosa, where it's a mirror lesion, mirror image lesion. Both sides were having more or less a symmetric lesion. When we thoroughly examined the other areas, we also saw that this part had basically already a history of biopsy from one of the sides. So we could check it again. We didn't repeat a biopsy, but we got the block from the patient and we just did a resectioning and saw that yes, this is consistent with something known as oral lichen planus. So this was very much consistent with that based on histopathology. Now, previously, many a times when they had visited certain doctors, even from different specialities, even from the medical specialities they had visited. So they had anticipated that it's just an ulcer and it will go away. And so in this particular case, it was not going away. So when we saw the histopathology and it was oral lichen planus, we have to understand in this situation what is the line of treatment, because oral lichen planus, again, as I said, there is no tobacco history, no history of any kind of even pan masala or smoking. But yeah, there was one history that is very, very important to ask in oral lichen planus whenever we are doing an investigation here, is basically to ask about how much is the stress level, because this is also a stress induced condition. Even we have to check two other things, because there is some syndrome which is called as the Greenspan syndrome, where we see diabetic patients and hypertensive patients having this particular oral lesion. As we all know, lichen planus is a skin condition which also affects the oral mucosa. It's like an autoimmune reaction where it is the cells, the immune cells are targeting the epithelial cells, and that is what causes this particular problem. So what we are seeing here is on the follow-up when we had checked the biopsy, after that 1 week and after that 2 weeks. So it was a very strict follow-up again. Because of this, we saw that within 15 days we could see a resolution of that particular lesion, that it was resolving, it was clearing out. Now, what did we use for the management? First is obviously to check the history. That will not show up here, but the patient history is very important. If they have stress, that doesn't mean everybody in today's time and age has stress. Even a school going student is having stress. So here in this situation, what was that stress? Now, this particular patient was basically having a very stressful job. So, and there were times when they had too much stress in their life. Like it could be financial, it could be personal as well. So based on that, a very delicately asked questions were, and you don't have to be very comforting to the patient. You don't have to be investigative, like tell me the truth right now. It's not like how you see it with the law enforcement officers doing. You have to be very, very, very considerate. Only then they will trust you and tell you this, that yeah, okay, we have a lot of stress about this and that. And so what was the line of treatment that we have? So in certain cases where the corticosteroids were already given, that also the patient had given the history, that corticosteroids basically like Kinacort and all these things were already given. So we had taken a other approach where we did the stress management as well with the patient. We tried to explain and educate the patient. So, you know that stress is going to cause this particular problem and it is going to worsen. And it can also be that you will start getting lesions on your skin, because here it had started in the oral cavity first. So based on that, based on the awareness that was created for this particular patient, they could follow up well with us. There were certain antifungal agents that were given as well, because sometimes see, when the oral mucosa is damaged, the most opportunistic infection is already there in our oral cavity in a dormant state, that is candidal infection, that is oral candidiasis. So antifungals were also given in this particular case. Now in non-pharmacological management, there are a lot of these low level laser therapies and light therapies that can be done, but these are mainly used for the skin lesions and natural, like even I mentioned curcumin, that is the turmeric, that was also used in oral submucous fibrosis. There are a lot of aloe vera gels and lycopene, which are antioxidants, which can also be used as adjuncts, and it can also help depending on the particular case from patient to patient. Now, in the next case, what we will be seeing here, in this particular case, we will be seeing something like a leukoplakia. And whenever we talk about leukoplekia is a clinical diagnosis. We don't call leukoplakia on any histopathology. Leukoplakia literally means a white patch. Now, this particular patient, yes, they had a history of having tobacco, mainly kind of basically the smoking history with the tobacco, and also having pan masala on and off. So they had stopped their habit for roughly 10 to 12 years when they became more aware. Now, this was a male patient in the late 50s. So they became more aware because their children, the patient's children mentioned it, tobacco is bad, and so you can stop, and it's not going to be useful. But they did stop. But however, after so many years, they formed, or they had this particular doubt that this lesion is, it was not white before. Many of the patients examine their tongue. They see, okay, this top dorsal part is looking little yellowish white. Yeah, normally it used to 20, 30 years ago, but I have never seen this side having a whitish patch. So they approached like basically they went to their physician to first show it, and physician then said, no, you show it to a oral specialist. So in that situation, they could, then they visited me. So what they could see here, this was on the right lateral and the ventral surface. So again, the proper reflection is needed. And on this side, I know the image is a little cropped, it's cut from here, but I'm using a sterile gauze, and I'm holding the tip of the tongue with my gloved hand and moving it to the left to examine the right side completely. So leukoplakia, when we see, okay, these are well-defined borders. So this patient did have a history. They feel that they've stopped since 10 years. It is not possible, but yeah, on and off, even in between, if they tried to have something, or they by mistakenly had a little pan masala for just the occasion, or a little pan, so they feel, okay, I think now I'm having very less, so they don't even mention it in the history. But we have to be very, very thorough when we ask the patient. Now, in this, we have to understand how to approach the management, or how to approach that white lesion, because we see a lot of white lesions. Even the OSMF will look white. Even the particular oral lichen planus will look white. So even leukoplakia is looking white. So first, you have to understand, is it scrapable? This similar kind of example I gave earlier. When it is scrapable, yes, it could be some superficial material. Any history of antibiotic use, because sometimes it will just consume antibiotics just for everything, and because the bacteria suppresses in the oral cavity, there is a imbalance, and candida, which is the most opportunistic, it becomes candidiasis, and that will also present as a white lesion. Sometimes there is a chemical burn. Sometimes they are asked to, you can take a thorough medical history, where they if they are having any kind of tablets which they have to directly swallow or keep it under their tongue, so sometimes that causes a chemical burn, something even like aspirin. So, but is it scrapable? If not, then is it opaque, rough, trismus, any areca nut or tobacco history? Then we saw one case of OSM. So this is very, very informative, and you can understand and directly jump here. Even normal things like when we say linea alba, now that's a normal physiological change. We see it in older individuals. And since this patient was in the late 50s, the age was around 58. So in that, we could say it's not lineal. But now this is, again, it is not because of constant irritation. What we have to rule out the other things, like any kind of verrucous carcinoma, or proliferative verrucous leukoplakia, and then papillomas, or any like the lichen planus case we saw before, and even the leukoedema. So we have to have a different approach. So in this particular case, yes, we did advise a biopsy, and we could see that yes, the situation, or the lesion is basically, we have reached a situation where it is consistent with a hyperkeratotic lesion, and which has a little mild dysplasia. So that is leukoplakia, not on histopathological diagnosis. So very, very important to remember this, that leukoplakia is not what you will see on the histopathology report. It is a clinical diagnosis. In this particular case, now again a female in the late 30s. Basically, the main complaint was again because in the lower front region here, the patient could see that there is some kind of growth which is occurring, which has occurred since the past, say, 2 3 weeks, and it was a short duration. So again, the patient thought they just need a cleanup, so they came for a cleanup. So after the cleanup, when we again examined, it didn't look like something that is just a part of the gum which will subside on its own after the cleanup, because there was some amount of calculus and the stains and all which had accumulated below the growth as well. So any kind of growth which is there on the gingiva, always remember this to diagnose. Three P's, the rule of three P's. That is it could be a pyogenic granuloma, it could be peripheral ossifying fibroma, or a peripheral giant cell granuloma. Now, in this particular case, we had suspected and informed the patient that this could be that these are the common occurrences, and not to worry that what it requires is a surgical excision, and it was excised completely, and this was the healing after 7 days of the surgical excision. And the histopathological report, it was consistent with the first provisional diagnosis on clinical examination, that was pyogenic granuloma. Again, pyogenic granuloma is a misnomer. So what we see on the report is a lobular capillary hemangioma, because the findings on histopathology are very much more consistent with the lobular capillary hemangioma. What we say is pyogenic granuloma, there's a lot of theories behind it, because once upon a time, there was any growth on the gums was just called a epulis. So epulis is also not a correct term, but here. So here, pyogenic granuloma, we simply call it a lobular capillary hemangioma that is consistent with the histopathological features. And still commonly, many of the time, we do call it pyogenic granuloma. The last case that we will be talking about now is a lesion on the hard palate. Here we can see that entire part of the hard palate is having this particular growth. We had a good illumination here. We could see that this is the entire mass of the tissue which is formed here. And what we are seeing over here is the entire tumor mass. Patient had obviously noticed it before, and since history was taken, the patient was also immunocompromised. It was seropositive. And in that situation, what we usually go by the textbook, we say Kaposi sarcoma, very common site is the palatal area, etc. So it would be, but then we first ran an incisional biopsy. And on the incisional biopsy, routinely we could say, okay, it might be just a kind of a, like an N mass or a tumor mass. But then what we were surprised to see that it is showing signs of a mixed tumor. There were various areas which showed myxochondroid stroma on histopathology, and so many other features that, it was consistent with something known as a pleomorphic adenoma, that is a salivary gland tumor. And a salivary gland tumor is basically a pleomorphic adenoma. The most common site is basically the parotid gland. And here, intraorally on the palate, it was a rare presentation. So, a biopsy is always conclusive to give a final diagnosis in this, and it was not anything that like Kaposi sarcoma or anything like like we see in an immunocompromised individual. So once that was confirmed on the incisional biopsy, the entire treatment planning was done. Acknowledgement to the colleagues in the oral surgery department and the oral surgeons. So they planned the entire process, and the resection was done. So pleomorphic adenoma, basically in an immunocompromised patient, this was also published. So a very rare presentation intraorally, but yeah. So pleomorphic adenoma, also known as the mixed tumor, it is the most common benign tumor of the salivary glands, and most common site being the parotid glands. So intraorally, again, this was a rare presentation. So with this, I would just like to say what are the take-home messages. So you have to perform a complete oral examination, irrespective of the hard tissue and soft tissue both. We have to not only look at the teeth, we have to form that habit. And the sooner we start, the better it is, because one day you might end up saving someone's life. You should always consult or refer to a specialist if you suspect a lesion. Sometimes there are certain limitations. We might not know everything. So there is no harm in always consulting or referring a specialist. If there is a lesion that you suspect, sometimes when the patient might not complain. We are always, if you are doing a root canal on the tooth number 3, 6, we are reflecting the buccal mucosa, and we are observing, okay, there could be a very initial sign or very initial white patch. Let me just scrape and check. Okay, it's non-scrapable. So if I'm not sure, I have to take a picture and I have to explain the patient. Let's see, you're smoking. Yes. You are having tobacco. Yes. So there is a chance that, you have something like a leukoplakia patch, and that requires some kind of treatment before it becomes a malignant transform, because before it becomes anything serious. That's how we tell the patient that, it will become a life threatening situation, that it will become a cancer. So please just understand that, we have to have this particular approach for your consultation, referring to a specialist. Early diagnosis and intervention can prevent malignant transformation, and you will end up saving somebody's life. And not only that, you will end up saving more lives, because that particular patient, now in some of these cases that you have seen, they actually become advocates. They also tell the same thing to someone when they see in their social circle that, you should not smoke because this what happened to me, and see, this is what my doctor told me. And now I can also tell you, I can show you the right path and avoid these deleterious bad habits which will cause or can potentially cause a bigger problem in the future. So early diagnosis and intervention can prevent malignant transformation of certain conditions. So at this point, I would like to say thank you, and wish everyone a very, very happy Diwali. And it was a true honor to be here on this auspicious occasion and talking about such an important topic. So happy Diwali to all of you. And if there are any questions, please, you can let me know.
Thank you so much, Doc. And I think if any participants has any doubt, you can type your doubts in the chat box so that doctor can solve your doubts. So I'm giving few minutes. If you have any doubts, you can type it in the chat box. Also, the participation certificate link has been shared in your chat box.